Ladies and gentlemen, welcome and thank you for joining today's conference, Strengthening Collaborations for State and Federal One Health Approaches to Avian Influenza. Please note that all participant lines will be muted until the Q&A portion of the call. We'll provide you with instructions on how to ask a verbal question at that time. You are welcome to submit written questions during the presentation, and these will be addressed during Q&A. To submit a written question, use the chat panel on the right-hand side of your screen. Choose All Panelists from the Send To drop-down menu. If you require technical assistance, send a note to the event producer or call our help desk at 888-796-6118. With that, I'll turn the call over to Liz Fernandez. Please go ahead.
Good afternoon, everyone. I'm Liz Fernandez with the Professional Development Services Branch, and I'd also like to welcome you to today's webinar. We have 6 speakers for today's webinar, and our first speaker is Dr. Julie Gauthier. Dr. Gauthier is with USDA APHIS Veterinary Services National Preparedness and Incident Coordination Unit, where she plans and coordinates outbreak responses for high-consequence animal diseases, such as avian influenza and foot and mouth disease. Our next speaker will be Dr. Matthew Biggerstaff. Dr. Biggerstaff is an epidemiologist with the U.S. Centers for Disease Control and Prevention. Following Dr. Biggerstaff will be Dr. Kelly Giesbrick. Dr. Giesbrick, she serves on the Cabinet for Health and Family Service in the Kentucky Department of Public Health as a state public health veterinarian and is the interim section supervisor for the reportable disease section. Next will be Dr. Connie Austin. Dr. Austin is the Illinois State Public Health Veterinarian and Infectious Disease Epidemiologist. Following Dr. Austin, we'll have Dr. Jennifer Brown, who is the Indiana State Public Health Veterinarian. And our last speaker will be Dr. Greg Suskovic. Dr. Suskovic is a senior veterinarian in charge of emergency planning at the Minnesota Board of Animal Health. Without further ado, I will hand it over to Julie.
Thanks, Liz. And one of the main reasons that we gathered everybody today was to give participants in our tabletop exercise next week in Springfield, Illinois, some background information on how the animal health response goes in an avian influenza outbreak, just so everybody has some background baseline information on how animal health authorities and public health authorities work together in order to stop the outbreak and to protect responders. The part that I'm going to talk for about 10 minutes to give some basic information on how we respond to a highly pathogenic avian influenza outbreak in the poultry flock, and talk about our 10-step process, not to get down into the nitty-gritty details, but to put on our risk analysis hats and talk about what the likelihood is at each of these steps that live virus will be present and the likelihood that responders might be exposed to the virus. Then we'll pass it on to discuss One Health and public health implications of a zoonotic avian influenza outbreak, should we have to deal with that in the future. One of the first stages of outbreak response is when the detection occurs, and when we go out to investigate a sick poultry flock, collect samples, and determine whether or not a flock is infected with highly pathogenic avian influenza. At this stage, this is a period of time when it's highly likely that there is live virus in that environment and that people have a very high likelihood of being exposed to the virus. Depending on the routine biosecurity precautions that is taken at a poultry premises, and that can vary widely, people may not be wearing adequate personal protective equipment, and so it's likely that they could be exposed to virus at that time. After a quarantine is placed and we've made that diagnosis of avian influenza infection at a poultry premises, the quarantine prevents unauthorized or prohibits unauthorized persons from accessing the premises. And at this time, movement restrictions are placed on the birds, poultry products, equipment, anything moving on and off the farm. And biosecurity procedures are heightened, and PPE use is initiated and required for anyone going on that premises. So at this time, again, live virus is very likely to be present, and exposure risk is starting to be managed so that people may or may not be exposed depending on how compliant they are with the biosecurity procedures and PPE use. Next, we have a goal of depopulating infected birds within 24 hours of making that detection of avian influenza infection in a flock. In order to complete that goal, we have a number of different methods that we could use in order to kill all the birds on the premises. The method that we use is dependent on the size of the flock and the type of operation, whether the birds are kept in cages or are loose on the floor of the building or outside, and the environmental conditions at the time. Cold weather, hot weather, various environmental conditions can affect how we respond. At this time, the strict biosecurity procedures and the PPE practices are in place, and access is limited to the facility, first of all. Only people necessary to go into the building would enter it or onto the farm. And there is a high potential that there is lots of live virus on the premises at this time with these birds until they're dead. The virus is replicating, and they are shedding virus into the environment. And so potential for live virus to be present is very high. The likelihood that people will be exposed is lower now that people are wearing PPE, but we can always have breaches, we can have noncompliance, we can have problems with PPE use. Once the birds are dead, the decay clock is running on the virus, so the virus cannot replicate outside of a live host. And now the time is running out on the amount of time that virus will be alive in the environment. So now our risk of live virus being present is decreasing as time goes on. And at the disposal phase of the outbreak response, we are going to be getting rid of those dead birds that could still be contaminated with virus, although the virus is not replicating and being shed into the environment. Disposal methods that we might use would include composting, possibly burial, maybe incineration, possibly rendering, and maybe landfilling. These options would really depend on the farm type, the geographic location, and the regulatory issues that surround the different types of disposal methods in that area, and owner preference is involved in that decision. At this time, again, strict biosecurity measures and PPE use, those practices are in place, and we're limiting access to the farm to only those people who need to be there to do the work. The potential for exposure of live virus still exists, although it is declining. So the risk here is until we've gotten rid of those contaminated carcasses, that risk is still there. Exposure risk depends on the compliance with our biosecurity procedures and our PPE use. It's possible for breaches in PPE to occur. Suits can rip, masks can be put on top of the head rather than on the face where they belong. And so there's still potentially an exposure risk, although it's decreased from that time when we had live birds on the farm. One of our preferred methods for disposal would be a composting process, and oftentimes this can occur inside a house where poultry were kept, and those compost piles would be contained inside rather than being put outside. There are cases where we cannot build windrows, compost windrows indoors, and we must put them outside. The windrow construction for compost piles is overseen by experts, and they're built according to strict protocols. We have daily temperature monitoring of those compost piles to make sure that they achieve the appropriate temperatures to kill the virus. That temperature monitoring continues for 14 days. If everything looks good and the temperatures are met, then we turn the windrows with heavy equipment, and then another 14-day period of monitoring continues before we can release that pile to be its ultimate destination, which might be spread on field. We need to have that compost expert to approve that pile as complete and ready to be released before it is. So at this point, the risk of live virus being present on farm is low and declining. That virus is not very hardy, and it will not survive in the environment for long, especially when you're talking about conditions of increased temperature. Next, we eliminate the virus from the premises using a variety of cleaning disinfection methods to be used. And one of the preferred methods would be to do a dry cleaning and a heat treatment. The dry cleaning consists of brushing or otherwise removing the organic material from all surfaces. Then we would apply heat treatment that usually requires us bringing in something like propane heaters in order to heat up the building and up to a certain prescribed temperature and time. This process of the entire cleaning disinfection process takes about 2 to 4 weeks to complete. In the past, we have used wet cleaning, disinfection, or chemical treatments. But the dry cleaning and heat treatment is efficient, inexpensive, and very effective. Again, at this time, we're continuing our strict biosecurity procedures, and PPE must be worn. So the exposure risk here is through lapses in biosecurity or PPE breaches. The likelihood of virus being present on this farm at this point is low to very low. Once we've completed our virus elimination steps, we do environmental sampling, which we swab various surfaces and submit those for PCR testing and virus isolation to determine whether we still have live virus on the premises. And the environmental sampling occurs during a period of time where the site is standing empty. There are no birds, no people entering it except when necessary. It's just sitting empty for at least 21 days, sometimes much longer. The environmental samples are taken by official personnel who are wearing PPE. Again, the biosecurity practices and PPE use are still going on. And our test results will come back and let us know whether we still have virus present on the farm. We'll get those back usually within about a week. So possibility of live virus being on the farm at this point is very low to negligible, and potential for exposure is low as long as people are wearing the prescribed PPE and following the appropriate biosecurity practices. Now, once those tests come back and let us know that the virus no longer is present as far as we can tell, as far as we can detect on that premises, then in order to restock and for the farmer to get back in business, we have to make a couple of assessments. One is the assessment of that premises, whether all of the requirements have been met for restocking, and that includes the rest time, the fallowing time, the environmental sampling results. And then the second assessment is of the surrounding area. So if the outbreak is still burning in that area, that farm would not be eligible for restocking, even though they completed all of their own requirements for that particular premises. And the approval for restocking is made in consultation between the state and federal animal health officials involved in the outbreak. Birds that are restocked to that farm must be AI clean, so they have to have been tested for avian influenza and come from free flocks before they're moved on to that farm. So that gives you an overview of the whole process, what we go through in cleaning up the avian influenza outbreak, and how we try to protect our responders, giving you also the periods of risk. So at this point, I'm going to hand this off to Matt Biggerstaff, who will talk to us about the One Health implications.
Hi, everybody. This is Matt Biggerstaff. Thanks for the time today. And I just want to let everyone know I'm at a disadvantage because we lost internet access at CDC about 20 minutes ago, so I can't follow the slides or see what I'm actually presenting. So just let me know if it appears what I'm saying isn't on the screen, because it probably means I've gotten ahead of where we're going. So if we could move to the slide that says previous monitoring recommendations in the U.S. So in response to large poultry outbreaks of avian influenza in the United States in 2014 and 2015, the U.S. CDC and USDA drafted joint monitoring recommendations for persons exposed to infected poultry in the United States. Given that we didn't know the risk of transmissions from birds to humans for these North American lineage viruses, we drafted stringent monitoring recommendations based on what we knew about Asian lineage viruses. These recommendations called for active monitoring a person's exposed to virus, and that really means someone whose contacts, someone contacts each responder daily to assess the health status. And this monitoring was recommended both during the exposure period as well as for 10 days after the last exposure period, using a pretty broad illness definition for respiratory illness or conjunctivitis. Persons found to be ill were swabbed and tested by polymerase chain reaction that really helped us detect influenza viruses. The next slide, please. These recommendations resulted in large numbers of people to follow over a long period of time and were very resource intensive, as anyone involved in these monitoring activities will remember. And so we really wanted to see if we could review the response data and revise the recommendations for monitoring based on the best available evidence we had. That's for the next slide. And as part of this review, we used several sources of data. We first identified the domestic bird detection events that were reported to USDA and OIE, and then to identify the total number of responders, or the denominator, we used USDA reports from each incident. Although these reports did not specifically state exposure status, we were able to limit the numbers to persons who were deployed to the field. That meant we really excluded persons who were at the incident command post only and never got out to do depopulation activities. For the numerator, we used state reports to CDC that reported any ill persons and testing results. Specimens were tested at state public health laboratories. And using these data, we calculated the percent positive among all exposed persons and generated 95% confidence intervals with them. All right, the next slide, please. And from December 2014 through June 2015, there were detections in domestic birds in 15 states, as everyone remembers. High-path North American H5N2 and H5N8 viruses were detected in both commercial flocks and backyard flocks, and over 50 million birds were affected. The next slide takes us to 2016, where we only had detections in domestic birds in one state, which was Indiana. And both high and low path North American H7N8 viruses were detected, and over 40,000 birds were affected. And the next slide, please. This takes us to 2017, where we had detections in 4 states, Kentucky, Tennessee, Alabama, and Georgia. And we had both high and low path North American H7N9 viruses detected, and almost 300,000 birds affected. And so the next slide actually summarizes kind of all of these detections in the past that we've had since 2014. So we've regularly had these bird outbreaks occurring, and we've had different viruses with both low and high path, which maybe indicates that low path viruses were circulating more widely and then were identified once the changes occurred to make it high path. All right, next slide, please. So this table outlines kind of the people who were exposed to the virus during the bird depopulation by job category. And so we divided this out into USDA, state and local, and contractors. And in 2014-15, there were almost 4,000 responders, with about 75% being contractors. In 2016, the response was much smaller, with only about 500 people exposed. And in 2017, the responses were mostly handled locally, and only 74 people were exposed. And in total, we had about 4,500 people on which we had data. And the average number of persons responding to an event on a premise or farm ranged from 6 to 58. I also want to highlight with this data that we don't have the numbers for farm owners and workers, who were probably small in number, but may have a higher risk of illness. All right, so moving to the next slide, which describes persons ill after depopulation. In this table, in column 3, we show the total number of persons exposed from the previous slide, followed by the number ill and tested. There were a total of 23 people that were ill and tested. There were thankfully no persons positive for an avian influenza virus. And the final column has the confidence interval. And although we detected no infections, our power to say this with confidence varied by year. Given the large number of responders in the first year, we have greater confidence when we say the risk of transmission of North American H5N2 or H5N8 viruses from birds to humans is likely very low. Even in 2016, the number of persons exposed to North American H7N8 infected birds was fairly high. So again, we feel relatively confident in saying the transmission risk was low. In contrast, in 2017, there were only 74 responders, which meant if the true risk of transmission were 1%, we maybe wouldn't have been able to detect that with so few responders exposed. All right, the next slide, please. So in summary, the number of persons exposed to infected birds varied widely, ranging from less than 100 to almost 4,000. And most of our data also was really among persons exposed while wearing PPE, which likely lowered the risk of infection. So we really want to think about looking at the kind of risk by virus. And we have the most robust data for the 2014-15 outbreak. But we still have some work left to see if we can tease out the risk of exposure to each of these viruses separately, especially in 2017 when we had so few responders exposed. But with this data, we really thought, can we change our recommendations for responders so that passive monitoring may be the kind of default exposure among persons who are wearing their PPE and they're responding to these H5 and H7 viruses that we have good evidence for. So on the next slide, I'm kind of going to go over the proposed changes to the monitoring plan, which I believe is still under review. But if a person is responding to a previously unreported avian influenza virus, a public health concern, then our recommendations wouldn't change, and active monitoring would still be recommended among all persons. So if we don't know anything about the virus that's shown up, then we're going to still recommend active monitoring of exposed responders. If responding to one of the assessed viruses, which were the ones I kind of went over, then we're still going to require active monitoring, or still recommend active monitoring of exposed persons who either did not have PPE or had a breach in PPE. But we're going to recommend passive monitoring of persons who were wearing their PPE. We would still want responders to self-monitor and report illnesses to safety officers during a response or to public health authorities after the response, so after they've gone home. So that will require still some education for people to know the signs and symptoms of influenza and kind of stressing the importance of reporting illnesses either during the event or after the event. We've also put some factors for reinstating active monitoring in the guidance, and so that would include new genetic, antigenic, animal model, or epidemiological evidence that suggests a change in transmission risk. So if there's anything that's giving us a signal that the virus that was previously assessed is changing, or the risk among exposed persons is changing, then that would potentially give evidence for going back to an active monitoring situations among all exposed persons, even those wearing PPE. Let's move to the next slide, please. So what remains the same with this kind of guidance compared to the past is really most of it. So we still want ill persons to be swabbed and tested by PCR. We'll still be recommending broad respiratory illness definition, the use of a broad respiratory illness or conjunctivitis as a kind of indicator for testing based on exposure as well. The reporting instructions during the response and after the response will remain the same. So that means either the APHIS safety officer for USDA employees during the response or contract safety officers for contractors during the response. Once responders return home, that will revert the monitoring to their state and local health office. We'll, at CDC, still be getting daily list of demobilizing responders, and we always ask that CDC is notified immediately when anyone is tested as part of this. So the next slide, please. I also wanted to briefly cover antiviral guidance, even though that doesn't exactly fit with this presentation. I think there was some interest in this as well. And so when you're thinking about prophylaxis for responders, so this is someone who is exposed but isn't really showing symptoms, we don't really recommend chemoprophylaxis for persons exposed while wearing PPE. And the decision to initiate this should be based on clinical judgment with consideration given to the type of exposure and whether the exposed person is at high risk for influenza. When we're thinking about treatment for responders, so people who are showing influenza signs or symptoms during their monitoring period, we continue to recommend prompt treatment while laboratory testing is pending, so we don't want people to wait until they have confirmed flu, and then you can stop this treatment if laboratory testing is negative. It's not like antibiotics where you want to continue the treatment all the way through. You can stop this treatment without a negative consequence. And so that is all I have for now, and I'd like to turn it over to Dr. Kelly Gisbrook for the next presentation.
Hi, everyone. Thank you. It took me a minute to get off of mute. So, all right, let me advance the slide. All right, can you guys hear me?
Yes, Kelly.
Okay, so my slide's not advancing. There we go. Okay, whoops, went too far. All right, I think might need help with the slides. Can we get back to mine?
Of course, one moment.
Okay, thanks. Okay, all right, thanks. All right, so we'll go to the first slide. There we are, now it seems to be working. First, I want to let everyone know that, so I've been in this position a year, and I have not actually been a part of an avian influenza response, but there was an incident last year in Kentucky, so I found all the notes and based my slides on that. And I think it was a good exercise for our state because a lot of things developed from there, and that's kind of what I'm going to go over. So there are two ways that the Kentucky Department for Public Health would get notified if there was some avian influenza. The first one would be if a person was sick and identified with it, kind of the canary in the coal mine. The second way would be if the birds were sick and tested and the Department of Agriculture was notified of a confirmed result, then they would tell us. So one of the two ways Kentucky Department for Public Health would get notified, and we would work with those partners to monitor the people. And that would be my main job, work with them, keep track of the people that are exposed, give recommendations on PPE, and then monitor. So we also discovered last year that a lot of the organizations will monitor their own people that are part of the response or workers in the operation, especially for the larger commercial operations. However, if it's a smaller backyard farm or there are contractors with commercial operators, then that would definitely fall on us to monitor. We also felt that a risk assessment should be completed to determine the level of risk and the level of monitoring afterwards, and if they would need prophylaxis. Kind of like he just went over with, you know, were they wearing PPE? Were they, you know, what was their exposure level? All right, next slide. Here we go. So this is our communication flow chart. Like any response, communication always turns out to be one of the most important aspects of things, since there would be a lot of partners working together. And what we would do at the public health level is conduct a working group right away, and we would include Department of Agriculture, possibly Fish and Wildlife, the local health department wherever the response is taking place, and also we have regional epidemiologists that would get involved. USDA would probably work with, and Department of Ag would work with the Poultry Federation and the farms, and then local health department would help distribute educational materials and with diagnostics. The state lab would be responsible for doing the testing, and then the regional epidemiologist would work one-on-one with responders and patients in containment efforts. All right, next slide. So internally, again, this kind of shows what I've already talked about, that we would be notified in one of two ways, either because there's a confirmed human case, might be the first one, or because the poultry are sick and tested positive. So from that point on, as a state vet, I would be in charge of coordinating everyone and getting in communication with the agriculture and the state vet who is under the Department of Agriculture and work with USDA. And then we would determine who would need monitoring. They would keep track of everyone who was on the farm and who responded and send us that information. We would, what they did find out is that this commercial operation, they wanted to do the monitoring themselves and then send the information back to us as things went on. But again, if it's a smaller operation, then we would do all of the monitoring. Okay, next slide. One thing we did was create several documents to help us. We created a, and I don't know where again, I wasn't involved with this. These are things I found while preparing for this, that I don't know if they borrowed it from another state or not. If so, thank you. So one of the documents is a 10-day self-monitoring document for the responders, unless they would be high risk and needed to be contacted, active monitoring, but I believe everyone was at 10-day self-monitoring for this event. Another document was educational information for people that were in contact with the flocks. We also created a management information, educational information for healthcare providers that was sent out to healthcare providers in the area, so they could help us look for people that had symptoms, and then also a frequently asked questions page for responders and healthcare providers that they could also give out. And then the last document was a page on symptoms and how to report if a responder did feel like they might be coming down with symptoms for avian influenza. So these are some documents that were created from the event. And last page, so lessons learned from this is that definitely had to be a lot of coordination between all the different partners. So apparently there were 2 cases that local providers picked up as symptoms that were compatible with avian influenza, and I believe they were treated. Only one of them actually had a PCR done, and I believe it was not the H7N9. On investigation of these people, they didn't have direct contact with the farms, so no known connection to the farm, so that's good that they weren't positive. But only one person was tested, so that's one of our lessons learned, is that emphasizing with healthcare facilities to please get those swabs for PCR so they can be identified what type of flu, if any, that they have. And as our first event, communication apparently between partners was slow and not perfect. And that's always a big issue, it seems like, with any event, is getting all partners involved and keeping those communication lines open. So it was a good lesson for me to learn, and interesting interesting stuff. Thank you. And I am passing it on to Dr. Connie Austin.
Thank you. Thanks for the opportunity to talk today, and I'm learning a lot from the other presentations, so I'm really glad to be able to participate. I don't have any slides today, but we do have a draft avian influenza plan. It's very minimal. Illinois does not have a large poultry population, and as you saw from that map, Illinois didn't have any yellow in it at any point. So our only brief experience with this has been when Indiana had a response, and some of the responders were USDA employees who lived in Illinois. And at that time, it wasn't clear, who monitors USDA employees. So I think now, at least that has been established, that USDA monitors its own employees. But one thing I wasn't clear on at the time was whether if they did develop illness, would we be notified so our locals could make sure they go to the proper place for health care, so that the best place to go for these employees. So one of the first things we have to worry about is sharing information with our ag department. And we've done this, we had to do this in a number of situations like sole virus, there's tularemia cases, et cetera. So I think we have a way to share information. In our rules for public health, we do have the ability to share zoonotic disease information with our reporting goes, animal cases are reported to ag and human cases would be reported to public health. So we can share information as needed if the situation would arise. In Illinois, the state health department would lead the response on the human side, but we do have over 95 local health departments, and we work with them on situations involving their own residents. So we typically would have a call with all the health departments that are involved and talk to them about what is needed for them to do. They would conduct any interviews or risk assessments with any exposed individuals. They would monitor anyone needing monitoring, and one thing I noticed about Matt's presentation too is that if there were PPE breaches, you might go to active monitoring. So I think in some ways you actually have to kind of monitor them, because how would you know if they had a PPE breach unless somebody was, making sure that they hadn't or had not had a PPE breach. If they are symptomatic, then the local health department again would make sure that they would go to a place for appropriate medical management and specimen collection. And on the human side, even in spite of the fact that sometimes we give very clear instructions on how to collect specimens, somehow they manage to be collected incorrectly. So really concentrating on making sure that the specimen is collected correctly would be important. We also have a way to share our information through a siren system, so we can very quickly notify hospitals, local health departments, or other parties about any particular situation that's ongoing. So that's how we would communicate with our partners within Illinois. We also have an online system called REDCap, where we can have a series of questions, and we've used this for measles monitoring and other kinds of contact monitoring. So people can go online and just simply say, hey, it's this date, I feel fine, and we can easily, at the state and local level, look at their responses and make sure that they're responding every day. So that's a very nice system that we use. We would also work with our emergency preparedness and local health departments for any PPE needs. Antivirals, one thing that does come up is that, if you ask people to go to their personal physician, that's fine if they have health insurance, but if they don't have health insurance, it can be, a little difficult to get them antivirals or the treatment that they might need. Another problem that we've had in the state, and I'm interested in how other states handle this, is we have difficulty with getting people N95 fit tested. With sole virus, we have found that veterinarians in the state, there's very few veterinarians who are N95 fit testing, so if anybody's looking at ways to help emergency preparedness with veterinarians, private practice vets do not have this, and we at the state level do not have the capacity to do this type of fit testing, so it gets challenging just if a vet is willing to see, let's say, a rat with sole virus. If they're not fit tested, it's difficult to make these arrangements. So for us, that's a big issue about how to get that fit testing done. Public information is also obviously clearly an issue, so we would have to work. We have a public information officer. They'd have to work with other parties to make sure that our messages that we are releasing about the event would be appropriate and in line with what others are doing. And our expectation, at least what I understand, is that USDA monitors their own employees. The one thing I wasn't sure of, if one of their employees were to develop symptoms, would we be notified so our local health department can make sure they direct them to the appropriate place for medical treatment or assessment. So our challenges, I think, would be the N95 fit testing, how to get antivirals to people if needed if they did not have health insurance, Communications is always an issue, how to communicate with the federal partners, other state partners, local health departments. Also, another thing that comes up is dollars for the response. If we somehow have to get antivirals to people, how do we get that done? If people don't have health insurance, how do we get them the health care they might need? We do have a data collection system, and we really love to avoid any duplicate data entry. So hopefully on the federal level, if they had to collect a lot of information, they'd figure out a way so we could enter it in one place and not have to do a lot of double data entry. So that's our thought processes in Illinois, and I will pass it on to Jen Brown.
Thank you, Dr. Austin. And looks like I have presenting rights now. So I want to tell you all a little bit about our high-path AI H7N8 outbreak in Indiana in 2016. We were the first state that got to try out the responder monitoring guidelines that were developed by CDC and USDA and circulated in late 2015 that were described by Dr. Biggerstaff a little bit earlier in the call. I'll tell you a little bit about how that went and one of the major lessons learned that came out of that. So please bear with me as I try to get the slide advanced. Okay, so in January 2016, we had high-path AI H7N8 detected in a commercial turkey flock in Dubois County in southern Indiana. And, of course, our Board of Animal Health promptly initiated surveillance within a 10-kilometer radius of that infected premises, and through that surveillance detected low-path AI H7 in 9 flocks in the surrounding area. 8 of these were later confirmed to have low-path AI H7N8, and one of those flocks was inconclusive. In total, by the end of the response, 65 commercial flocks had been tested and 105 backyard flocks had been tested. 12 flocks ended up being depopulated, all 10 of the flocks that I just described, in addition to 2 flocks that were determined to be, one flock that was determined to be a dangerous contact, and about 414,000 birds in total were depopulated during the response. This was such a complex response involving multiple agencies that it's difficult to determine the total number of responders, but I can tell you that the number of on-site personnel at the response site peaked at 516 people in one day on day 4 of the response. So we talked with CDC about implementing those responder monitoring guidelines. The objectives for our monitoring program were to quickly identify ill responders, make sure that they were promptly evaluated, assessed for the need for antiviral treatment. Of course, we wanted to make sure that they could be tested quickly to rule out the possibility of zoonotic infection, and then we wanted to make sure that appropriate infection control measures were promptly implemented for anyone who was ill. Consultation with CDC determined that the probability of zoonotic infection associated with this outbreak was low, but not zero, and so we decided to push forward with responder monitoring, and we adapted the risk categories that were described in that monitoring document. If people had no exposure to potentially infected birds, of course, we classified them as being at no risk. And then we classified people who did have contact with potentially infected birds or their environment while wearing PPE to be at low but not zero risk. And then people who were exposed without wearing PPE, we classified as being at some risk. We didn't want to classify anyone as being at high risk due to the overall low concern that, that this particular strain would be zoonotic. You are all no doubt aware of the recommended PPE for a response event like this, but this is a picture of what that looks like in the field, and this picture is courtesy of my wonderful colleagues at the Board of Animal Health. And so our monitoring plan was based on these risk classification categories. So people who were classified as being at no risk did not undergo any monitoring. People classified as being at low but not zero risk were contacted on day 1 and day 10 following their last exposure by the local health department, in Du Bois County, and then self-monitored for flu-like illness in the intervening time period. And then people classified as being at some risk were actively monitored by the local health department for influenza with daily contact by phone call, text, or email. We define influenza-like illness as being fever with cough or a sore throat, or conjunctivitis alone, or with other respiratory symptoms. And I have to apologize, I lifted this slide from a very old version of this presentation and realized right before the call that it's out of date. So actually in that second column describing responders that were monitored by the state or local health department, the total should be 166 state and local responders, including 93 farm workers or residents, 67 officers and volunteer offenders from our state correctional system, and 6 local USDA employees who had completed their response activities. The numbers of people who developed flu-like illness and were tested are correct. So we had 14 people who developed flu-like illness in the monitoring period. We were able to test 12 of them, and as has been previously reported, none of them were positive for influenza H7N8. So one of the things we learned from this outbreak is that breaches in PPE were very common, especially tears in Tyvek suits. And in fact, this was reported to be so common from our colleagues in the field that we had serious concerns that breaches in PPE were not being completely reported. And so talking with our colleagues at the Board of Animal Health about using PPE use as a marker of the degree of monitoring that a responder should receive is potentially problematic. And so for future outbreaks, if a detection event occurs and the strain is one where we have a high level of concern for zoonotic infection or where the risk of zoonotic infection is unknown, this is probably how we're going to be adapting those CDC, USDA responder monitoring guidelines. Rather than looking at PPE status, we're simply going to be looking at whether or not a responder entered the exclusion zone or the hot zone of the response premises or the contamination reduction zone or the warm zone. Basically, we're saying anyone who enters the warm zone or the hot zone is going to be actively monitored, and anyone who didn't will not be actively monitored. And we can see 2 advantages to that approach. Here's what that's going to look like. This is a USDA schematic of a response site. You can see the green area would be the cold zone, the support zone. The yellow area is that transition zone between the cold zone and the hot zone. And the gray area is the exclusion zone or the hot zone. So anyone who goes inside the red line, we would be actively monitoring if we have a high level of concern for zoonotic infection. And the 2 advantages we can see to doing it this way are, number one, that if there are unreported breaches in PPE, we will still be catching those people in our monitoring program. And number 2, just logistically, we thought that it would be easier to develop a line list of people requiring monitoring based on their entry status into these zones compared with their PPE status, because as Dr. Austin pointed out, in order to determine if someone had a breach in PPE, you still do have to talk to everybody. So we anticipate that this approach will simplify our approach to monitoring responders in future events and would welcome any feedback on that plan. And with that, I will turn the microphone over to Dr. Greg Suskovic.
Greg, your phone may be muted. Please unmute your line.
Okay, thank you, Dr. Brown. I think I've got it unmuted now. I'm going to take a little bit different approach to this than my public health colleagues. I'm going to take more of a animal disease response attitude towards this, because the Board of Animal Health in Minnesota is a separate agency. And we have sole statutory authority to respond to an animal disease event. We are the only agency that can quarantine, depopulate, restrict import of animals, et cetera, et cetera. And to that extent, in both in the Board of Animal Health Emergency Response Plan and in the Department of Health, Minnesota Department of Health Emergency Response Plan, they both state that any animal disease response, the Board of Animal Health will be the primary agency and the Department of Health will be a supporting agency. That's even written into the Minnesota Emergency Operations Plan. However, what's also written into all those plans is that that would be the case except if this is a zoonotic disease. Then the Department of Health will be the primary agency and the Board of Animal Health would be providing support to the Department of Health. In discussions with Dr. Joni Sheftel, who is our state public health veterinarian in the Minnesota Department of Health, we kind of realize that this probably is not a very practical situation. And that since we have the authority to handle animal disease control issues, possibly that the Board of Animal Health should have be the primary agency in all animal disease responses and not just if they're not zoonotic. And then the question comes in is, how would we define the potential for a zoonotic disease that the Department of Health would take over? We're currently in the process of considering rewriting these plans and having the Board of Animal Health being the primary agency for everything, including zoonotic diseases. That being said, what I would like to talk about is how we have tried to incorporate a public health situation into our highly pathogenic avian influenza response. So following our 2015 event, we're writing up a new response plan for any unexplained poultry mortality event. We realized we needed to get something involved with the public health. So we have included in our initial response email, the first email that goes out on a poultry mortality event, we've included Dr. Sheftel, who is our public health veterinarian, Dr. Stacy Holzbauer, who is also in the zoonotic division of the Department of Health. So they are immediately notified that we have a situation that we are currently investigating. I've also taken and redone our animal disease response organization chart and have incorporated both Dr. Holzbauer and Sheftel into our IMT structure as the Human Disease Surveillance Unit. Currently, right now, they are involved in our, they are incorporating the Command and General Staff portion of the IMT. But I think that if we came to the point that the zoonotic disease would be a major issue in an event, I think I would put them into operations as their own operational division. So what they'll do is that in the event, and this is up to them, and that's why they would have their own separate unit, is that they would then contact workers and responders and start doing their surveillance that CDC would recommend. One of the things that was brought up in our other speakers is fit testing and proper PPE. All of our responders, my case managers, my Depop responders, they are all currently fit tested to 4 respirators, N95 respirators, and they all have access to PPE to take care of all things. So with that, I'm going to let her go, and if anybody would like to talk about anything, we can do that. Thank you.
Okay, we do have one written question, and it came during Kelly Giesbrecht's presentation, and it says, is this for a confirmed case in a human? I think you were talking about one of your slides, the diagnosis of having a positive for HPAI. And this person wanted to know if it was a human case.
And just unmute your line.
Kelly, can you hear us, or are you still muted?
Kelly is not on the line at the moment.
Okay. I will get that question to her, and I will get back to the person that wrote to me.
And if you would like to ask a verbal question, please press #2 on your telephone keypad. And just a reminder to submit a written question, use the chat panel on the right-hand side of your screen. Choose All Panelists from the Send To drop-down menu.
We do have a written question that just came in. It says, are there any resources for free fit testing for a department?
Yeah, this is Connie, and I was going to say we've had, a number of opportunities trying to get private veterinarians fit tested, and it is very difficult. The last situation we had was stool virus where we needed a rat tested. We finally found somebody across the river in St. Louis who would do it for $40, but we have not been able to find kind of free fit testing, so it's good to think ahead of time about how you would get this accomplished if, non-USDA employees need to be fit tested.
Hey, this is Greg Suskovic in Minnesota. I can respond to something on that. The Board of Animal Health contracts with the Minnesota Veterinary Reserve Corps, and the coordinator of that is currently working on getting herself trained to be able to do fit testing for practicing veterinarians in the case of a situation where they would need that. One of the problems is finding, getting the equipment to do it and to find places that will do medical exams for it.
Hey, this is Kelly.
Go ahead.
Sorry.
Go ahead, Kelly.
I was trying to unmute and I accidentally hung up. So was there a question for me earlier, or did
I think it's okay. They were asking about whether it was a confirmed case in a human.
So we did not actually have one, but if there was, that would also trigger events. But no, we never had one.
Okay. The next written question is: was there any data regarding how many of the monitored persons were vaccinated against influenza?
Hi, this is Matt. I don't believe we had data on that. States maybe have collected that individually, but we didn't receive that at CDC.
Okay. Are there any other written questions?
There are no further verbal questions or written questions.
Okay. Well, I'd like to thank all the speakers for your time and great presentations, and thank everybody who joined us for this webinar today. This webinar will be hopefully posted on the PEP website, hopefully no later than late on Friday afternoon, early on Monday morning. And I'm in the process of scheduling some additional webinars in the next coming months, and I'll be sending out that information as soon as it becomes available. So have a great afternoon, everybody.
Thank you for joining today's conference. The call has now concluded and you may disconnect.